I'll give you a quick introduction. So Dr. Vineeta Singh is a breast surgeon at Royal Perth, Armadale Hospital and the Mount, and is a specialist breast surgeon of the Royal Australian College of Surgeons. More than 15 years experience managing breast diseases, both benign and cancer, by working overseas as well as Australia. She has extensive experience in managing surgical emergencies, general elective surgery, and has a specific interest in breast cancer research and surgical education. She believes in the importance of forming strong patient-surgeon bonds with effective communication, which often helps to reduce psychological stress from cancer diagnosis. Thank you, Dr. Singh. I'll hand over to you.
Thanks, Ellie, for the introduction, and welcome everyone in the COVID era of Zoom meetings. Although this is not my preferred modality to meet, I like to meet in person and exchange ideas with my colleagues, but we are stuck with this now. So today I'm going to just give you an update what has happened in the space of breast cancer surgery in last few years. And I'll just trying to see the screen changing or not.
You should just be able to arrow to the right.
Yeah, just not. I think the screen share. Okay, let me see. Can you see the change of screen?
Yep, sure can.
Yeah, so my clinic locations are in Perth Breast Clinic, Mount Hospital, and Armadale Breast Clinic, and also at Royal Perth Hospital. And I operate mainly out of Mount, Hollywood, and Subi, and in public at Armadale and Royal Perth. Now, the updates I'm planning to give you is in terms of some imaging techniques that have changed our surgical practice due to various different presentations. So there's like additional imaging that we routinely do in some cancers, especially if you're doing breast conserving operation. Some newer techniques in localizing occult or small tumors, surgical techniques, especially Oncoplastic breast surgery and reconstruction with local flaps and free flaps. And I'll give you a brief overview of intraoperative radiotherapy that has been kind of restarted after 15 years in Perth. So in terms of risk assessment and additional imaging before surgery, in last few years, we have seen that there's been change in additional imaging pre-op due to reporting of breast density and invasive lobular carcinomas being more radio occult. And if you try to do breast conserving operation with these type of breast tumors or dense breast, we end up getting multifocal disease that are undiagnosed pre-op. So to start with breast density, there's actually a big organization in US. It's called rudense.org. So before 2004, it was not mandatory to report breast density around the globe. And it started with a patient, Nancy, who had a normal mammogram and then within a year had a recall, within a year found to have breast cancer. And the surgeon said, oh, actually you had dense breast, so maybe it wasn't seen. And then she got angry that why I wasn't told that I had a dense breast. So since then, the first law was passed in 2009 in Connecticut. Following that, it has been legislated in most countries to notify women after their screening mammogram that they have dense breast. What does that mean and what are the implications? As we can see, a lot of women get this report from Breast Screen WA saying you do not have any evidence of breast cancer, but your mammogram shows that you have a dense breast. Now, breast is made up of fatty tissue, ductal elements, and fibrous element. And if you look at the image of these two mammograms, the first mammogram A, it's very hard to find a cancer in this dense breast as compared to other one, which is fatty, and it's very easy, you can detect. So if a woman is known to have dense breast or notified, what should we do with that? And does breast density actually increase the risk for breast cancer, or do we just miss it? So this is a breast density from A to D with increasing density. So As we can see, it's much easier to find a cancer in group A and B as compared to C and D. Just if we just do a mammogram and not do any additional imaging. So this is a woman who had actually a palpable abnormality, but you can see in image A, her mammogram was so dense you could not see anything. Then she had an MRI scan, and we can see the subtraction image shows in picture C a clearly defined lump. And it was then she had a targeted ultrasound, and that showed the lump and found to have a malignancy, which could easily be missed if we just relied on the mammogram. So what are the clinical implications of having a dense breast? It is thought that dense breast most likely is an independent risk factor for breast cancer, as a lot of women with dense breast have got proliferative breast disease, which is a marker for increased risk for breast cancer. And if we do core biopsy on women with dense breast, we do often find atypical hyperplasia or a lot of fibrocystic changes with or without calcification. As compared to women with predominantly fatty breast, women with extreme density have more than 4 to 6% increased risk for breast cancer, but luckily only 10% of women have extremely dense breast. So in general, they are twice as a higher risk than general population to have breast cancer, and there is 7 to 10 times risk of finding interval cancers. So the interval cancers are cancers found between 2 mammograms. And apart from that high risk, there is a risk that the cancer will be quite obscure on mammogram, and if we don't do additional tests, it will be missed till it becomes a big lump. So this is a picture. It's actually a tomosynthesis of one of my patients recently who presented with a self-detected lump in her breast. The mammogram showed a 28 millimeter mass. It wasn't a very dense breast, and ultrasound showed the same. The core biopsy came as a high-grade DCIS. So she had a wide local excision and sentinel node biopsy, but it showed that she had got more than 20 foci of invasive duct cancer, and it's quite aggressive one. It is ER/PR negative and HER2 amplified, and 5 centimeter of DCIS with involved margin. So with this woman, before I go and excise involved in medial margin, I would like to know what her rest of the breast looks like, because this is a quite occult tumor not seen on mammogram. Most of it was not seen on ultrasound as well. So we have got two main modalities of contrast imaging. Either we can do a contrast enhanced mammogram, or we can do an MRI scan of the breast with gadolinium to further characterize the breast and see what is the extent of the pathology. So this woman actually ended up having a contrast enhanced mammogram, and we can see in the upper outer quadrant where there is stromal distortion from the previous surgery, there's a faint area of enhancement, and the radiologists think that all small enhancing area that is seen on the contrast enhanced mammogram, this is next to the surgical cavity, is all disease. So essentially this lady needs a mastectomy because there's a lot of enhancement outside the surgical cavity. Similarly, this is another patient whose mother had breast cancer in her 50s, and she had a recent mammogram with breast screen WA. It was reported as normal, but within 2 months of that mammogram, she noticed that there is some asymmetry in her left breast lower outer quadrant in the skin. Then her GP organized an ultrasound. The ultrasound showed that 2 lesions, 12 o'clock 9 millimeter, and it was reported possibly a fibroadenoma, and another indeterminate lesion with some distortion, but no defined pathology seen on mammogram or ultrasound. She had a core biopsy of the stromal distortion, and it showed invasive lobular carcinoma, and this is the ultrasound. There's not even a defined lump on ultrasound. There's just a bit of a distortion. So that's very typical of lobular carcinomas. You don't really see a lot of desmoplastic reaction, and they don't form masses. So this lady, because of the lobular pathology, I did MRI scan, and you can see she had extensive disease in her breast in the same quadrant where it has been reported normal on mammogram and hardly seen on the ultrasound. So most of the lobular cancers, I do MRI scans or contrast enhanced mammogram because there will be a lot of occult disease that will be missed. So finally, she had a mastectomy, and that showed a 9 centimeter of invasive lobular carcinoma in her breast. Another example is of a 41-year-old lady found a self-detected lump in her left breast. She had a very dense breast, more than 75%. On the mammogram, the density was more than 75%. The mammogram was reported absolutely normal. On ultrasound, they said there's a lesion at 5 o'clock, possibly fibrous tissue, possibly of multiple hypoechoic nodules, but they were not sure. So she had a core biopsy of this 5 o'clock fibrous tissue, and it showed a high-grade DCIS. Now, to make sure the rest of the breast is fine, she had a MRI scan, and you can see on MR, there's a 5 centimeter area of nodular non-mass enhancement at that 5 o'clock region. And this led to a mastectomy that showed a 45 millimeter of high-grade DCIS. So significantly now, on and on, I find that additional imaging in dense breast or lobular carcinomas is leading to a wider cancer detection. And I think in future, this will reduce the recurrence and relapse rate. Well, we are all familiar with this ultrasound of some patients, and we don't really know what to do. So this is a 41-year-old lady. She had multiple nodules in both breasts, and she has been having serial surveillance ultrasounds every year. So this time she went to a plastic surgeon because she wanted breast augmentation, and she repeated the ultrasound. Now, it's very good on the radiologist to pick up among all these nodules a new indeterminate or suspicious irregular hypoechoic foci suspicious of a malignancy. Following that, she ends up having a mammogram. Now, this is the mammogram. You can hardly make out, the breast is so dense that where is her cancer? Then we did a contrast enhanced mammogram on her, and you can see there are 3 very clear foci of malignancy on the contrast enhanced mammogram, although there is a lot of background enhancement due to density of her breast, but we can clearly see the 3 lesions. So she had a left skin sparing mastectomy and sentinel node biopsy, and it showed exactly the 3 tumors, 12 millimeter, 11 millimeter, and 6 millimeter excised with clear margins. Just for comparison, I'm showing her right breast. So the right breast also had a lot of enhancement, but there was no well-defined nodule, and it's all benign. So that's the new thing that we have started in last few years, additional imaging in dense breast and lobular cancers before proceeding for surgery. So that's going to be commonly used. Contrast enhanced mammogram is only available in teaching hospitals. Royal Perth and St Charles Gardner is not available in private, except for in Bunbury. I think SKG is doing it in Bunbury. MRI breast is rebatable if there's a clinical indication and is available through private providers, especially if the specialist is asking a specific question, then most likely it will be rebatable. Now, there's been some changes in localization of smaller lesions that were not palpable. So we are all familiar with the hook wire guided excisions, and the problem is that patient has to come in the morning to radiology. It can't be done many days before. They have to wait long, and we have to often delay theaters because they are not ready. So at Royal Perth especially, we have started using radio guided seeds for localization. So this is pretty much placed similar like the patient had a core biopsy, and the seed is lodged at the site of tumor, and it can be lodged at least 7 days before the surgery. And this is radioactive iodine labeled seed. At the time of surgery, we use a special probe, the gamma probe, on the settings of iodine, and it helps us localize where the seed in the tumor is. And you can see the excised specimen comes out something like this. There's other way to localize is now is being used in Australia, and I think in WA is being used in Bunbury. It's called mag seed because it does not involve any radioactive seed. So these lesions can be localized by placement of a small seed, and it can be placed at least a month before the surgery. So there's no problem. You can see the patient and plan the surgery at least 2-3 weeks in advance. This is made from medical grade steel, and it is implanted into the breast tumor either by a mammogram or ultrasound, depends on how the tumor was detected. And we have got a special probe. This is the probe that is used to localize the seed in the tumor. Now, the other problem we often face is injecting a sentinel node on the day of operation, the technetium-99, or night before. But there's a new technique that has come. It is called mag trace. It is approved for use in Australia. In Eastern states being used, but in WA, I don't think we are still not started to use it. So this is, there's no radioactivity involved, and the surgeons can actually inject it into the patient 7 to 10 days before, and the lymph node can be detected using the same probe that we use for the magnetic seed. So, and it can be even injected on table just before the operation, so makes it much easier. The patient doesn't have to go to nuclear medicine. So that's something to watch in future. Possibly it will ease our operating scheduling. Now I'll give you a quick update on breast cancer surgery, what has been the recent changes with some reconstruction, and especially touching on anaplastic large cell lymphoma arising out of breast implants that has caused significant concerns to the patient, and also targeted axillary dissection. I am aware of the time. Do I have only till 7:30?
Oh, no, you can go, Vineeta, it's okay.
Okay, thank you. So for breast conserving surgery, you must have heard the word oncoplastic breast surgery. So level 1 oncoplasty is when less than 20% of breast volume is excised. There's no excision of the skin involved, and we just mobilize the local flaps and do the reconstruction. Level 2 oncoplasty is when we are anticipating removing more than 20 to 50% of breast volume. Then we have to remove the extra skin and reshape the breast, adjusting the localized breast flaps, and there are various mammoplasty techniques that I use. So it's based on what quadrant the tumor is. So round block or bat wing is a common one. It's usually for tumors in the 12 to 2 o'clock position. This is again a tumor that is present at 12 o'clock. We can use inferior pedicle mammoplasty. This is a racket mammoplasty for a lower upper outer quadrant tumor. This is a Lejeune mammoplasty for 6 o'clock. So based on the various localization of where the tumor is and how much volume, we mobilize the breast tissue and shape it accordingly. And this is a level 2 oncoplasty that's very commonly used. Now, the important thing doing this oncoplasty is that we should always mark the tumor bed for the radiation oncologist to give a boost to the tumor bed, because once we have moved the pedicles around, it's hard for the radiation oncologist to know where the tumor bed is. This is an example of a VY mammoplasty. The lower inner quadrant is a very difficult area to do breast conserving operation because there's not much breast tissue to mobilize. So essentially we make a cut and mobilize the lateral breast pedal and move it around. And you can see the scar here. And it heals really well and gives a good shape to the inner quadrant. Now, the other techniques are using a localized flaps. So they are pedicle flaps. So we can use either a flap based on lateral intercostal perforators, or we can rotate the flaps into the defect. Or there is a lazy S flap that is based on the lateral intercostal perforator. It can be lifted and placed in where the defect is. So they are all localized flaps, and on the morning of operation, we mark the perforating vessels, deepithelize the skin, and free this up entirely from the chest wall, and wherever the defect is, we undermine and tunnel it and place it, and that gives a good volume correction to the breast. Now, these are free flap techniques and usually used after a mastectomy operation. The anastomosis is usually done to the internal mammary artery. The flaps can be taken from various places. The commonest is the deep inferior epigastric flap that is taken from the lower abdomen. There could be superior gluteal flap. There could be a tug flap from the gracilis muscle. There are various places where the flaps can be raised. based on the local perforators. They can be lifted and completely freed from the place and then put into the breast after the mastectomy has been done and anastomosed. This is mostly done as a microvascular technique, and I use my plastic surgery colleagues for this type of reconstructions. Now, the other type of reconstruction is implant-based reconstruction. It's patient choice, and based on their body habitus, we decide which kind of reconstruction they want. And more so, patients are now choosing to have flat-based reconstruction after TGA had a recall on some of the textured implants. So in pictures, we can see these are smooth implants and these are textured implants. There has been a recall of Silimed and elegant textured implants because of the increased risk of anaplastic large cell lymphoma arising from these implants. So this is a story that is published on the TGA about a patient who noticed the unusual painful swelling in her breast and was found to have breast implant associated anaplastic large cell lymphoma. So the TGA has ordered the withdrawal of the macro textured implants. They are the Allergan implants and Silimed. The Mentor implants are still in use, but most surgeons are not using, and I don't use any textured implant. We use either a smooth implant or a Motiva implant, which are a nano textured implant. The first case of breast implant associated ALCL was reported in 1997. And after that, there has been a lot of reporting. So far in Australia, I think we have got 90 cases. The risk is 1 in 3,000 with Allergan implants and 1 in 60,000 in Mentor implants. The risk is still very low, but given the amount of implants that are being used in various patients, we have to be careful if they present with significant symptoms of swelling or fluid around the implants. What is the reason for this anaplastic lymphoma? So there has been an extensive research that why we are getting a lymphoma from implants. And essentially it is related to the inflammation and presence of chronic bacterial biofilm onto the implant, and that gets seeded at the time of surgery. And because the textured implants have got a greater surface area, they promote higher levels of bacterial biofilm growth and likely cause of the anaplastic lymphoma. The gram-positive infections that are often seen immediate post-op are not the cause for ALCL. They usually cause capsular contracture, but the anaplastic lymphoma is usually associated with a gram-negative organism that is found in the theater atmosphere, Rhizonia piquetii, and this has been isolated from the biofilms. And this is actually resistant to most of the antibiotics, but it is found to be susceptible to 50% solution of poiodine iodine. So the surgeons who wash their implants in iodine, their risk of getting a lymphoma is very, very low. So to reduce the risk of anaplastic lymphoma, we have devised a 14-point surgical plan. So it's important to use antibiotic prophylaxis at the time of surgery, but also try to avoid contamination of the implant with the skin. So wash and prep the skin just before insertion of the implant again, change of gloves, and try to minimize devascularized tissue, get good hemostasis, and soak the implant in either triple antibiotic or povidone iodine solution, pocket lavage with povidone iodine solution, and use of smooth or nano-textured implants will reduce the risk of anaplastic lymphoma. Now, these are the common, this is the frequency of some of the common used implants that has caused the lymphomas, and it has been studied. So as you can see, Allergan implants have got the highest number, followed by Silimed. And it's just because of the surface area of all of these implants that they have caused greater formation of bacterial biofilm. Now, this is a picture of a 39-year-old lady who presented with unilateral sudden swelling of her breast. And that is a common presentation for anaplastic lymphoma, usually happens 5 to 6 years after the implant has been placed. And the MRI scan shows that there's a lot of fluid buildup around the implant. This is the fluid aspirate showing lymphoma cells. She was then treated with the removal of the implant and the capsulectomy, and most of the patients, this treatment is successful. If they have advanced stage, then they will need a lymphoma chemotherapy. But generally, if they are detected early with just fluid around the implant, then removing the implant and complete capsular excision will cure these patients. So this is the staging from anaplastic large cell lymphoma. As you can see, if there's a lymph node spread or there's infiltration outside the capsule, then most patients will need chemotherapy. So the TGA has advised that not all patients who have got textured implant need to have them removed, because the risk of having ALCL is really low. So there's no need for patients to come and get the implants removed unless until they have got any symptoms. Now, the second topic I want to cover is the changes in the management of axilla. So the standard of care has been that we do a sentinel node biopsy on clinically negative axilla. And if there is lymph node involvement on the sentinel node, most patients used to go for axillary clearance. But this has changed in past. Now we do axillary clearance only if patients have got macrometastatic disease in the sentinel node. That is, the deposit in the sentinel node of tumor is more than 2 millimeters. And also, all of these patients also have an option of having radiation and not having axillary clearance. We have got a study that we participate, is mainly run through Fiona Stanley and Sir Charles Gardner. It's called PostNoc study, where we are trialing if instead of clearance, patient can be given only radiation treatment. This is all to just avoid the long-term risk of lymphedema. There's another study that we have started called targeted axillary dissection, where we all patients who need chemotherapy or neoadjuvant chemotherapy and have got involved lymph nodes, we clip the lymph nodes, and at completion of neoadjuvant chemotherapy, we remove the clipped lymph node. Those were the involved lymph nodes seen on the ultrasound, and also do a sentinel node. And if patients have got complete pathological response, there is no need to do axillary clearance. This does not aid in the survival. So the aim is to accurately stage the axilla, but also reduce the frequency of axillary clearance and reduce the morbidity from axillary clearance that happens to most of these patients. Now, I will briefly touch on intraoperative radiotherapy because we have kind of restarted this. So in 2005 and 6, I participated in a study called Target Study, and that was done at Sir Charles Gardner Hospital. So what is intraoperative radiotherapy? So we know that most patients with breast conserving operation will need external beam radiation treatment or radiotherapy given to the patient, and usually it is given over a period of 4 to 6 weeks, and it is every day, and some patients find it really difficult. So intraoperative radiation treatment is a procedure that the radiation is delivered directly into the tumor bed at the time of primary operation. And if a patient is suitable for this, then it will not need external beam radiation. But remember, this is only used for a very, very small subgroup of patients with a very low risk disease and very small tumors. And most patients are elderly women in 60 or 65 plus with strong ER/PR positive disease and less than a centimeter tumor. All these patients are presented before the intraoperative radiotherapy is given to the MDT and recommended that, okay, IORT will be suitable for them, but it's a very small subgroup. So targeted intraoperative radiotherapy versus whole breast radiotherapy study was done in 2005 to 2008 at Charles Gardner Hospital. It was a part of international project, and it was a non-inferiority study. And at end of that study, we found that the patient who had targeted intraoperative radiotherapy as compared to external beam radiotherapy, the recurrence rate after 3 years of follow-up was pretty much equivalent. So it is an option for very small subgroup of patients to deliver treatment directly into the tumor cavity. So this is a picture how we give it. So after the tumor has been excised, this is the intrabeam that is placed into the tumor bed, and we pack rest of the cavity with the wet gauze to protect the skin. Then it's all covered with a sterile sheet, like you can see here. We move out of the room, and radiation physicist will then do the measurement, and they will deliver the beam directly into the cavity. It usually takes 20 to 25 minutes of the delivery, and the procedure is done. If in post-op pathology, the tumor is much bigger than what we expected, or margins are closed, then all of these patients will have external beam radiation treatment. That's all the updates from breast cancer surgeon's perspective. Thank you very much for your listening. Any questions?
Does the intraoperative radiotherapy affect wound healing?
It doesn't affect wound healing. So the target study showed that the wound healing was not a problem. The only problem was these patients had a bit more seroma formation, because we are unable to close the cavity completely with like we do with Oncoplasty now. So it's only for very small tumors where no Oncoplastic technique is used, and there's hardly any skin loss. It's very, very small volume tumors. The seroma rate is higher, but the infection rate is not that high.
Great. Thank you so much, Dr. Singh. I'm just checking if anyone has their hands raised for a question. It doesn't look like it. So you're good for now.
Yeah, I'll stay on here. If someone wants to ask a question at the end, it's fine.
Yeah, sometimes we have some questions at the end. That would be great. Thank you.
No.
All right, if you can end the sharing of your presentation and then let Ari jump on and share his. I'll introduce you while you're organising that, Ari. So Dr. Ari is a medical oncologist who works out of St John of God, Subiaco, CliniConnect, and also down in Albany. He's completed his medical training in New South Wales and WA hospitals, and spent some time over at Newham University Hospital in the United Kingdom. He treats all solid organ malignancies and accepts patients who do not have proper diagnosis for workup. He strongly believes in improving the quality of life of patients undergoing cancer treatment while achieving the ultimate best for his patients. So thank you, Ari. I'll hand over to you.
Thank you very much. Hope you can see my screen.
We can.
Okay.
Perfect.
So, let's see. Oops. I am going to talk about neoadjuvant chemotherapy in breast cancer. The breast cancer chemotherapy is a fairly vast area with a lot of research going on all the time. And neoadjuvant chemotherapy is something that coming up quite strongly these days with breast cancers, and patients get quite anxious about neoadjuvant chemotherapy, thinking, oh, why am I having chemotherapy rather than getting the cancer out initially? So this is just to educate people about how neoadjuvant how and why the chemotherapy is preferred initially, especially in certain groups of breast cancer. So just giving quick demographics about breast cancer incidence in Western Australia. This is just a few years back, a couple of years back. So breast cancer is the commonest cancer in females in Western Australia, accounts for about 30%, colorectal cancer coming second. Mortality-wise, it counts for the second largest cause of mortality, 15% of deaths of all cancers. So treatment in breast cancer, there's three main groups that you can change them into neoadjuvant, where we give chemotherapy before the surgery, then adjuvant chemotherapy, where we give chemotherapy following surgery, and chemotherapy in metastatic setting of breast cancer. These are just few types of treatment that we have. This is just a small group. Actually, there's a lot of other investigational treatment that's come up and we use in various settings, trial settings. So we use anti-estrogen treatment. We've been using anti-estrogen treatment for quite a long time. CDK4/5 inhibitors have come quite strong in managing metastatic breast cancer patients, and we use it quite commonly now and reimbursed in PBS. Chemotherapy as usual, and then immunotherapy is coming in, especially in triple negative breast cancer setting, in neoadjuvant and also in metastatic setting, neoadjuvant in trial settings. And we can use PARP inhibitors again in trial settings at the moment in BRCA mutated breast cancers, and we use trastuzumab, which is Herceptin, Tridem, and also TDM1, which is Kadcyla. So the indications for neoadjuvant chemotherapy, when I initially started training, chemotherapy was used neoadjuvant, especially when it's also only, well, mostly when it's inoperable cancers for downstaging and patients who are requiring breast conserving treatment when it's not possible otherwise. Now it's coming more importantly in to assess response in chemotherapy to guide further treatment options, and it's more common in HER2 positive and triple negative breast cancers because we have a lot of other treatment, a few other treatment options available to improve the outcome of these patients. In simple terms, if you look at this diagram, it will show easy way of understanding the breast cancer is there. Then you give chemotherapy. If you get PCR, which is pathological complete response, so when you do the surgery, there's no cancer left in there. And then you have some patients who have residual disease, which have responded to a certain extent, but there's some cancer there. So it's easy that patients who had complete response have a better outcome compared to patients who had residual disease after treatment, meaning their cancer was bit resistant. So US FDA actually uses complete response in neoadjuvant treatment to accelerate, get drugs in, accelerate approval of drugs. Going through basics, before starting neoadjuvant treatment, we do investigations prior to that with CT scans, bone scans that now there's NAF, sodium fluoride PET CT scans available as well, especially Q-scan does it in Rockingham area. And also PET scans. PET scans are also available now, reimbursed on Medicare as well in patients who need it. Neoadjuvant treatment of breast cancer. So neoadjuvant chemotherapy is if you take the outcome of these patients, they're similar outcome, considering if you give adjuvant treatment for these patients, and the response differs according to the tumor subgroups. The complete response rate is less, it's only about 8%. So we are not very keen on, at the moment, giving neoadjuvant chemotherapy for hormone receptor positive breast cancers because their complete response rates are not great. But in patients who have HER2 positive and triple negative disease, they have complete response rate of about 50%. To start with neoadjuvant chemotherapy in HER2 positive cancers, so more patients with HER2 positive early breast cancer achieve complete response, pathological response. And we have seen this even without HER2 directed treatment. And if we add on HER2 directed treatment into neoadjuvant setting, their outcomes are much higher. Complete response rates are quite much higher. In a meta-analysis in 2012, adding trastuzumab increased complete response from 23 to 40%. Phase 2 trial, pathological complete response was increased from 19 to 38%. So fairly similar numbers. And again, this shows the benefit of having a complete pathological response. This is event-free survival on the first graph. And what you can't see in blue on the top is patients who had complete pathological response. And on the low, which is not really red, but grayish, is actually patients who had residual disease. So those patients, they had their event-free survival was low as opposed to patients who had complete response. And in overall survival, which is the ultimate outcome of cancer studies, as you can see, patients who had complete response had a higher overall survival compared to patients who had residual disease. So who should be considered for preoperative systemic treatment in HER2-positive disease? So we would prefer normally patients who have a tumor size more than 2 centimeters, or patients without, regardless of the tumor size, if they have node-positive disease, we would prefer to give them neoadjuvant treatment as long as they don't have metastatic disease. This is a simple, so one of the other things that came up with HER2 treatment, Herceptin treatment in neoadjuvant setting is that they also added on pertuzumab, which is another HER2 blocker. And that showed patients who had trastuzumab and pertuzumab combination had a higher response of complete response compared to patients who had single agent. So the one in the bar in yellow is a combination treatment with trastuzumab and pertuzumab and chemotherapy, and other groups which uses single agents. Or this is the one in blue is actually without chemotherapy. This is the Catherine trial that you heard initially as well. So what they did was, so patients who had neoadjuvant chemotherapy and residual disease following neoadjuvant chemotherapy, they went on to have TDM1, which is Kadcyla, for 14 cycles. And then another group of that study was to give trastuzumab for 14 cycles. This study, well, going trastuzumab, TDM1 is a combination drug combining the Herceptin or trastuzumab into emtansine. Emtansine is a microtubule inhibitor and kills the cancer, so it's a chemo monoclonal antibody combination. So in the Catherine study, as you can see, the patients who had TDM1 had a better outcome as with disease event-free survival, as opposed to patients just had trastuzumab. Especially if you can see the distance recurrence rates were less compared to trastuzumab alone, as opposed to TDM1, which is 10% as opposed to 15%. This shows distant recurrent rates and also overall survival rates. You have to understand, again, here, if you look at it, the lines actually almost overlap. Nevertheless, these patients already have quite a good outcome with treatment. So this study actually has a hazard ratio of 0.7. So it's quite a good positive study showing that their overall survival has improved with TDM1 as opposed to Herceptin alone. So this is what we normally use for well, suggested treatment pathway at the moment for HER2 positive disease. Of course, if smaller tumors go on to have surgery alone, but larger tumors, we give neoadjuvant chemotherapy. With chemotherapy plus Herceptin is what is PBS reimbursed. Pertuzumab is not PBS reimbursed at the moment, but both can be combined. And if they have residual disease, then they go on to have TDM1, whereas if they have pathological complete response following surgery, and then they go on to have Herceptin for another year. All right, let's then go into the triple negative cancer setting. So triple negative cancer, breast cancer, is the most lethal form of breast cancer. It's common, more common in younger women, and it's higher risk of earlier relapse and high risk of visceral metastatic disease. And patients who have metastatic disease from triple negative cancer, their prognosis is about 18 months normally. But this is a very chemosensitive cancer. And patients who have complete response end up actually having similar outcomes to patients who do not have triple negative disease or hormone positive disease. So triple negative breast cancer, importance of neoadjuvant chemotherapy is to assess the response. And as I mentioned earlier, they have better outcomes if they get complete pathological response. And patients who do not have complete pathological response, we have other options that can improve survival. These are common chemotherapy types that I use for triple negative breast cancer. I actually quite commonly use dose-dense AC and paclitaxel. And adding carboplatin is a thing. It's controversial. There's no overall survival benefit shown from adding carboplatin, but it certainly has shown increased complete pathological response by adding carboplatin. So I just want to also show this study, which is a current trial that is run in certain places, where we can add on immunotherapy to chemotherapy in triple negative breast cancer, which the agent used currently is pembrolizumab. And then following surgery, they go on to have pembrolizumab in adjuvant setting as well. As the immunotherapy actually has shown improved survival in metastatic setting. So we are trying to see if that can be imposed into neoadjuvant setting as well to improve the outcomes of patients. So we don't have full data on this, but patients without events or event-free, so free of events or death, as you can see, patients who had immunotherapy and chemotherapy are higher as opposed to patients who had placebo and chemotherapy. So neoadjuvant, CreateX trial is what we use. I told you that if there's residual disease in triple negative breast cancer, there are other options which we can do. There's a few patients I treat currently with capecitabine. So what we do is the trial has shown that patients who had residual disease, if we give them capecitabine, which is another chemotherapy agent, is the tablet form for 8 cycles, it's normally 3 weekly cycles, their outcome is better. So that's why the importance of doing the neoadjuvant, because it's not just that we get to know that whether they respond better or not, or whether their outcome is better or not. If we know that their response to chemotherapy is less, or their response, the cancer is more aggressive, we can do other things to improve their outcome. So CreateX trial shows here actually, so on the top are patients, all comers, basically they have had triple negative and hormone positive cancers, but the lower two graphs are actually in triple negative patients. It shows the lines are separating quite widely on patients who had capecitabine as opposed to patients control, which is who did not have active treatment after neoadjuvant in disease-free survival as well as in overall survival patients. So prognostic value of pathological complete response, I mentioned earlier, it's now used as a surrogate marker to accelerate approval of drugs. This graph is probably not that clear, but if you look closely, patients who have HER2 positive, hormone receptor negative disease with trastuzumab had a better outcome and overall survival better with pathological complete response, and also triple negative. So triple negative and HER2 positive disease, high grade especially, their outcome is better if they get complete pathological response. But this is not a black and white area either. Patients who do not have complete pathological response are not doomed. They have a vary of outcomes as well. So this is showing that, you know, with the amount of response, the outcome actually differs, especially in triple negative and HER2 negative, HER2 positive breast cancers. It is not very clear when it comes to HER2 positive breast cancers, which shows that we need to try and find other markers other than ER and PR to try and separate out these patients so we can, you know, target these patients better. All right, I would like to conclude my talk by just in the importance of side effects when it comes to primary care physicians. The importance is, so what kind of side effects to expect from chemotherapy and other treatments that we are doing for breast cancer, and to also alleviate the anxiety of patients who are having treatment, not having the surgery done upfront. So nausea, vomiting, tiredness, common side effects of chemotherapy. Hair loss, this can be avoided in some centers by scalp cooling, not 100% guarantee, but it can be reduced. And cardiac toxicity associated with anthracyclines and trastuzumab and pertuzumab, where we check their cardiac functions, especially patients on HER2 blockers, will get cardiac functions assessed every 3 months. And before starting chemotherapy with anthracyclines, we assess their cardiac functions, but they are at risk of complications and has to be kept in mind. And hematological malignancies, especially associated with anthracyclines, these patients run a risk of 1 to 2% risk of developing hematological malignancies down the track. And also, as with any chemotherapy, risk of febrile neutropenia is a complication. Well, thank you.
Fabulous. Thank you so much, Ari. That was a nice, informative